a podcast sponsored by To Enlighten Research. I'm Sara Siqueira. One of the bases for scientific evidence development is to test clinical practice findings, and when there is a solid scientific evidence, it allows clinical decision making for better patient treatment care. So, the importance of the whole research process includes using the proper statistical method for enlightening the process instead of being only a support. The main challenge that Dr. Feldman was dealing with was to decide how to statistically evaluate his mitral valve surgery data retrospectively, considering severe primary mitral valve regurgitation surgery treatment, such as valve replacement to a biological or mechanical prosthesis or mitral valve repair. At that time, his clinical observation for his exceptionally surgery technique ability suggested that patients who underwent mitral valve surgery repair were more likely to have a better evaluation when compared to the classical treatment of mitral valve surgery replacement. Here, it is important to elucidate what makes survival analysis different from classical statistical analysis. In this episode, we count on the illustrious presence of Amanda Siqueira to talk about this whole topic. Welcome, Amanda.
My pleasure, Sarah. Thank you for having me.
As in the philosophy of ideas word, the scientific evolution in mitral valve disease treatment did not appear from nothing. The Auguste Comte philosopher idea of the living are always and never increasingly governed necessarily by the deaf still remains over time. In this sense, let's start talking briefly about the history of mitral valve surgery and the importance of scientific evidence base for the advancement in treating mitral valve disease.
Yes, Sarah. In 1923 started the heart valve disease treatment at a place today known as Brigham and Women's Hospital in the US. At that time, Dr. Elliot Cutler developed the digital commissurotomy to treat rheumatic mitral stenosis. Later on, he created the cardiovalvulotomy, but this strategy transformed the stenosis into a severe mitral regurgitation. Despite this technique did not succeed, its idea was the basis for mitral valvuloplasty, and then in 1925 in England, the Sir Henry Suter performed the first transatrial finger commissurotomy. The cardiopulmonary bypass era in 1950s and 1960s helped to develop the first repair for mitral valve regurgitation by Dr. Clarence Watto Lilly in 1957, and Dr. Nina Starr-Browald was the first to implant a mitral valve prosthesis in 1960s. Afterwards, Dr. Albert Starr and the engineer Milo Edwards produced the first artificial prosthesis. In addition, in 1970s, the importance of preserving the subvalvular apparatus to guarantee an adequate ventricular function after mitral valve surgery was indicated by Dr. Miller and colleagues. Then, the reason for maintaining the integrity of the papillary cords and muscles turned crucial, and at the time, the mitral valve repair was demonstrating the best technique for this accomplishment. Important to note, Sada, that in 1980s, relevant outcomes when performing mitral valve repair were being presented. But late results with prosthesis implantation, although good, also demonstrated several issues, such as porcine valve degeneration over time, thrombosis in mechanical prosthesis valve, and the need of anticoagulant therapy, and also infection as endocarditis. Besides, Dr. Carpentier showed the French correction by preserving the valve apparatus, and this technique allowed for a better knowledge of repair surgery in mitral regurgitation. Then, several techniques spreaded, such as the mitral valvuloplasty with annular support, the Carpentier ring, and mitral valve repair without support ring by Dr. Renato Calil in Brazil and other surgeons around the world. Over time, Sada, The successful results with mitral valve repair spreaded, and several other new techniques with this approach arose. This surgery turned it into the choice in the entire world when having eligible patients with mitral valve regurgitation with adequate valve anatomy for this strategy and if performed by experienced surgeons for this procedure. All these mentioned steps, all research and technology improvement, bring to better elucidation of mitral valve regurgitation treatment and also culminated to development of mitral clip procedure for inoperable or higher surgical risk patients who attend the eligible criteria.
Perfect, Amanda. As we can see, it is essential to have information about specific details in mitral valve regurgitation, not only in the valve treatment but also in the etiology of mitral regurgitation disease, pathophysiology, and complications. In mitral regurgitation, the leak volume increases the preload with increased systolic work due to Frank-Starling mechanism and decreases left ventricular afterload because of the low impedance of the left atrium. Thus, the left ventricular ejection fraction level can remain normal or elevated for long periods, but it does not refer to preserved left ventricular systolic function, only by observing a normal ejection fraction value. Moreover, the severity of heart contractile dysfunction can be masked. Therefore, over time, the left ventricular cavity diameters increase as well as the muscle mass, resulting in eccentric hypertrophy but with preserved systolic function. However, when the mitral regurgitation and the ventricular cavity dilated continued increasing, the ventricular hypertrophy cannot preserve the intercavitary pressures, and symptoms and serious hemodynamic imbalance started to appear. Moreover, the progressive ventricular dilation increases the left ventricular filling pressure with ventricular contractile loss, and the efforts to eject blood both into the left atrium and to the aorta becomes insufficient, and the ejection fractions start to decline due to an increased end systolic volume. At this point, the renin-angiotensin-aldosterone system is stimulated due to systemic perfusion reduction associated with increased filling pressures, which results in enhancing peripheral afterload, apoptosis, and ventricular interstitial fibrosis, an important loss of left ventricular contractile power.
Very good, Sada. And all this mechanism is important to access the parameters for mitral valve surgery or mitral clip procedure. Here, the disease stage in terms of acute or chronic disease, chronic symptoms or asymptomatic condition, left ventricular and systolic dimension, the ejection fraction, the pulmonary hypertension, new onset of atrial fibrillation, the high probability for repair, the surgical risk, left atrial index volume are these essential parameters. Also, Sada, when considering the primary etiology, there are leaflet and chordate tendinea involvement, and that's why, for mitral valve repair, it is crucial to evaluate the mitral valve anatomy and also the mitral valve regurgitation etiology, since some conditions can contribute for extensive valve degeneration, like in case of rheumatic disease or other etiologies when there are not favorable anatomy and therefore in certain conditions the mitral valve repair is forbidden. As we have talked, another decisive factor is the surgeon experience since mitral valve repair must have to be performed only when the surgeon has the ability for this procedure.
Yes, Amanda, there is no doubt that this is one of the main parameters to consider. Whenever possible, it is mandatory to perform mitral valve repair, as it demonstrates a lower surgical mortality and better long-term prognosis. When there are limitations for mitral valve repair, the option is mitral valve replacement. But even so, the surgeon must try to conserve the subvalvular apparatus, maintaining the corda tendineal and its connection. And as you mentioned, Amanda, in the past, when valve replacement involved all valve apparatus removal, the ejection fraction became worsened after the surgery, which highly increased mortality. However, when the surgery is performed with preservation of subvalvular apparatus, the ejection fraction rates tends to remain at preoperative levels. For this reason, the contractile dysfunction of the left ventricular is the main determinant of survival and postoperative prognosis.
Exactly, Sarah. When the surgical technique is adequate and the indication time of surgery is well chosen, the survival rate of these patients are very close to those of the general population. Talking about other factors, it is also necessary to take into account for patients' comorbidities and age, the surgical risk by STS score and EUR score, combined valve surgery with coronary bypass surgery, surgical time, eligible criteria for mechanical or biological prosthesis, post-surgical complications, which can also impact the survival rates.
Wonderful, Amanda. Now back into Dr. Feldman challenge. Let's take a look at the options to analyze his mitral valve surgeries data retrospectively, considering severe primary mitral valve regurgitation surgery, such as valve replacement or mitral valve repair. The options are: first, using ANOVA linear regression model to assess quality of life in both groups, mitral valve repair and mitral valve replacement, throughout the SF-36 quality of life scale measured once a year. This approach provides results in an easy way to interpret, however, the clinical significance of the result is decreased. The second option, using survival analysis and log-rank test. The time until the patient's death in both groups, mitral valve repair and mitral valve replacement, is defined as the outcome, and it will be expressed throughout Kaplan-Meier curves and compared by applying a log-rank test. Here, the groups can be compared by survival times. However, it's not possible to account for covariates. The third option, adjust for covariates using survival and Cox proportional hazard model. In this way, it is possible to account for covariates instead of just comparing the survival times between groups that have different characteristics. So, Amanda, what makes survival analysis different from classical statistical analysis?
Well, Sarah, in survival analysis, the dependent variable is the time until the outcome of a certain event, such as death or any other event, and it compares the time a participant develops this event. Conversely, in the classical statistical analysis, the dependent variable is the occurrence of a certain event, such as developing a disease or the cure, etc. Also, it is known that during the study, some participants do not reach the total time expected for follow-up for many reasons. In the classical statistical analysis, since the patients were not under observation all the time, they will be excluded from the analysis due to unclear information about the time to develop the event. While in survival analysis, even if participants do not develop the event in study, the data of these participants are used in the final analysis. Here, the censoring concept is a recognized characteristic in survival analysis and is described as the insufficient participant data about the survival time. As a result of loss of follow-up over the study, competitive events, which means death due other condition not expected, dropouts, and so on. In this sense, sensory participants are the ones that, in the course of the study, will not experience the event of interest, or, in other words, When the investigation period is stopped, the event has not happened. Hence, survival analysis allows the use of information for all participants until the event develops or until they are censored. So, it is an ideal approach to analyze binary outcomes to have or not to have an event in longitudinal studies when there are different follow up times between individuals and loss of follow up. In addition, survival analysis also allow us to assess the pace at which events are happening between groups under the study, while using a classical statistical analysis can only allow us to evaluate this characteristic after an arbitrary period of time, which implies in a vague answer and quite different from the real. And Sada, how data analysis is done when using survival analysis?
Here, Amanda, one of the methods is Kaplan-Meier, and for this approach, the time of follow-up is divided at intervals. And the limited time is related to the time of follow-up in which there are events. It is important to note that due to different recruitment times, the participants' observation time only starts to count from the moment they enter the study.
And how to compare different groups and how to interpret the difference, Sada.
To compare groups, we use the hazard ratio, which is the probability that the participants who did not have the event until a certain moment have it at this moment. So, hazard ratio compares the instantaneous incidence that the events occurred in the different groups. While the risk of deaths is the number of deaths divided per the number of total participants, the hazard is the number of deaths divided by sample observation follow-up. So, this method takes into account the chronological aspect of time. And survival time is very important because an individual who dies within the first few days after surgery is much more serious than the one who dies more than 5 years later, as death 5 years later offers a longer survival time. In the classic statistical analysis, death at any time has the same relevance and therefore there is not a detailed information. Ideally, hazard measurements needs a longer follow-up. Using hazard, there is a perspective beyond the risk and computes the importance of each subject in relation to the time that the subject contributed to the event. Moreover, the ratio between the two groups is the hazard ratio. And another advantage is that the hazard measure takes into account the cumulative incidence of the outcome, which means that there is a conditional probability. For example, a group of people who survive the first year of post-surgery has a lower hazard than the risk of the group of people who were at the beginning of the study. But Amanda, this conversation doesn't end here. Another way to compare the different groups is by using the median survival, that is the time at which half of the subjects have experienced the event. And this information is obtained using the Kaplan-Meier curves. Also, it is possible to directly estimate the survival at the end of any time interval using Kaplan-Meier curves. Now, to assess whether the difference between the two groups is statistically significant, the log-rank test is used to calculate the p-value. And how to deal with different characteristics between groups, Amanda?
This is very important, Sarah. When groups differ from the start due to a small sample size, lack of randomization, or when there are possible characteristics that can impact the difference between groups or in the outcome of interest, adjusting for covariates is essential. So here, a multivariate analysis can be used to obtain this information. For survival analysis, the Cox regression or Cox proportional hazard regression is a significant test to compare groups in multivariate analysis. Now, Sarah, after this detailed overview, I believe it is possible to answer Dr. Feldman's challenge. In cardiology, when indicating a surgical or other invasive procedure for the patient, the goal is to reduce mortality and improve symptoms.
For sure, these are our intentions, Amanda. So, an important primary outcome here is time until death. And to start using survival analysis is a good option. However, Dr. Feldman has retrospective data. And different from prospective studies such as randomized control trial, in observational studies, there is a limitation to exactly define the time of event, and consequently the inference of a survival effect can be unsure.
Great, Sarah. Moreover, as we extensively commented, there are several characteristics that turn groups different between each other, and also it can provide difference between the group's treatment, and as a consequence, they can affect the outcome. For these reasons, having the survival analysis between groups without taking into account the covariates can bring a not real answer for the study.
I see, Amanda, and we are thinking the same way.
Sure, Sada. To conclude, our choice is for using survival analysis adjusting for covariates by Cox proportional models and considering a proper sample size, this approach can be the best option for this study. In addition, assessing improvement in symptoms can be a proper secondary outcome.
Thank you so much for your participation, Amanda. It was an excellent discussion.
My pleasure, Sarah.
Regarding this topic, our special thanks to Dr. André Feldman, our Brazilian Feldman cardiologist, for being our professor during the medical school and for all the experience and knowledge when teaching us during our cardiology fellowship in intensive care after cardiac surgery. Also, our special thanks to our professors and family from PPCR for the everyday learning process. Thanks for listening.